So our first topic for today's medical conference is comorbidities and complications in young onset diabetes. So for this particular topic, we have speaker Dr. Purushottam Chatterjee, who is a very well-known endocrinologist. And to chair this particular session, I would like to welcome Dr. M.L. Bhansali, who is the Vice President of Howrah Town Diabetes Study Society and the founder member of the same. And he's a senior physician and cardiologist from Howrah. We have Dr. Ashok Kumar Mukherjee. He's also the senior most physician from Howrah and also the patron of Howrah Town Diabetes Study Society and having more than 40 years of experience. I welcome chairpersons and I welcome speaker for this session.
Hello, hello, hello. Hello, hello.
Now it's my proud privilege and also an honor to chair the session of Howrah Diabetic Society Conference, 8th National Conference consecutively. And today's topic of discussion, as you all know, is comorbidities and complications in young onset diabetes. However, we all know, particularly the diabetic health workers and practitioners, that prevalence of diabetes in young adults, particularly below age of 18, is increasing year by year, and that is being unnoticed by almost all of the healthcare givers or physicians or diabetologists. We are basically concerned with type 1 and type 2, particularly above the age of 18. However, below the age of 18, the cases are increasing exponentially. And SARS study and Tourette trial has also disclosed that it is being more common with much complications without type 1 diabetes in the adolescent age group, and say many factors, particularly adolescence, obesity, family history, negative autoimmunity, everything has got some role, and they are also associated with multiple comorbidities and complications like macro and microvascular complications, for which we have none other than the great orator, speaker, diabetologist and our famous endocrinologist of Apollo Clinical Hospital, Dr. Purushottam Chatterjee. I think he doesn't need any introduction here. Actually, he is also a researcher and a clinician. And without wasting time, I'll hand over the mic to Dr. Purushottam Chatterjee to start his deliberation. Dr. Chatterjee, please.
Hello. Good morning, everyone. Thank you. The organizers, respected chairperson, and it is a very important day for us. It's a Mahala. I wish you a very happy Durga Puja ahead. So today I'll be, just a minute. Today I'll be talking on a very important issue. And before starting, before starting my talk, I would like to tell you certain truth regarding the diabetes in young. There is serious lack of evidence-based data all over the world. In India, we have very little, if no data. And third, whatever data I will present or whatever evidence I will give is mostly from the Western population. So it is unfortunate but true, we have very little data even all over the world regarding the diabetes in young. So if you look at the available evidence as far as the epidemiology of diabetes in young, it is very difficult to predict the prevalence and incidence of young onset type 2 diabetes all over the world because it varies differently in different geographical region and ethnicity. So IDF has tried to identify the areas where the prevalence is high, is low, but we still don't have definite data. But roughly I have calculated the incidence of diabetes. It is all over the world, mostly below 18 years. Type 1 is the predominant type of diabetes, and type 2 diabetes varies from rare to uncommon depending upon the region, but it is increasing in certain areas in the world. In 18 to 14 years of age group, and I would like to say that diabetes in young is mainly identified in people below the age of 40 years of onset. And if you consider the age group of 18 to 14, mostly it is a type 2 diabetes, and there are other heterogeneous cause of type 2 diabetes, including type 1. So below 18, it is predominantly type 1, but type 2 is increasing, and 18 to 14 is mostly type 2 unless diagnosed otherwise. If you see the global data, except few areas of America, Central America, and other parts where there are indigenous population, but the diabetes in young is very high. You can see the blue arrow, the Southeast Asia having the highest number of young diabetic patients as far as prevalence is concerned. And if you look at the right side of the graph, this is the data from SARCH trial in United States. You can clearly see that there is a high prevalence of type 1 diabetes. It is increasing below 19 years of age. But if you see the different age group, the yellow bar, they show the prevalence of type 2 diabetes below the age of 19 years. And it is at least double over 5 years of gap from 15 to 20. So it is also increasing largely. If you see the Indian data, there are very few data like cures, that's longitudinal study, and INDIAB study recently been published. It has shown that the onset of diabetes in India is at least a decade, even earlier. It has been said by the INDIAB study that it is around 25 to 34 years. The Indian onset of type 2 diabetes, and we can call it a young onset diabetes as far as the available definition. So we have diabetes early onset, and that is in young age group. This is very important to understand. This is from the largest data collection from Pan-India study. And there is a few small and personal studies in India and Bangladesh. It has shown that over the 2 decades of gap, there is a doubling of prevalence of young onset type 2 diabetes both in Bengal and India. And there are few unpublished studies from some personal private centers. They have also shown increase in young onset type 2 diabetes in their population. Now, if we see the latest publication in American Diabetic Association and Diabetes Care, young onset type 2 diabetes, there is a clear indications that I have already mentioned the indigenous population like American Indian and non-Hispanic black, they have high prevalence of diabetes. And if you look at this red arrow, the Asian and Pacific population in USA having also increased in the prevalence of young onset type 2 diabetes below 40 years of age. Now, diabetes always comes with a lot of baggages, the comorbidities and its long-term complications. If we look at that, before going into detail, I would like to just show you data from 2 important studies. One is young onset diabetes in Asian Indians, and their genetic factor and insulin secretion was compared, and that Indian data was for ICMR and from Mohon Center, and ESDC was a Scottish database. They were compared through a AI-driven mechanism, and they have found that our young diabetic people has less BMI, but more abdominal or visceral fat compared to the European one, and our beta cell function is impaired from the very beginning, and lastly, that is genetically determined. This is not a randomized controlled trial or a well-designed trial or is a large trial, but initial evidence shows that our patients with young type 2 diabetes has a different pathophysiological mechanism compared to the European. Now, in another studies, it has shown, and this is well known, that probably young diabetic and adult type 2 diabetes have got different subgroups depending on the beta cell function, insulin resistance, and their BMI. So they have found several subgroups, like someone with a significant insulin deficiency, other having increased insulin resistance as compared to the Western population. So probably we have a type 2 diabetic patients, particularly in young, in this paper has shown they are a little bit heterogeneous from deficient beta cell function to increased insulin resistance. So we have a mixture of different population of type 2 diabetic patient in young in India. Now the comorbidities and complications, again I must say that our main knowledge came from these two trials, today and search trial. They are little bit different, and it is very difficult to compare these two trials as far as the outcomes are concerned, but I will try to make out the essence of these two trials, what the trials are trying to tell us, and it is definitely important and interesting if you understand. So if you look at the comorbidities or risk factor, the search trial, one of the largest done in United States, 72% youth with type 2 diabetes had at least one type of comorbidities, maybe hypertension or a complication like nephropathy or retinopathy. So it is not that it is benign. Majority of either having a comorbidities or a complication when the diabetes started at youth. Regarding the risk factor, the common risk factor that is associated with the pathogenesis of this young onset type 2 diabetes, female sex is found to be an important risk factor in Western population, not in Indian population. We don't have any male-female differentiation as far as risk is concerned. Obesity and overweight, this is very important because as you know, though there is obesity epidemic in young and childhood, and parallelly there is increase in type 2 diabetes in childhood. So they have got something common in them. Low birth weight, as you understand, the low birth weight and the intrauterine environment has got some role to develop early onset diabetes, beta cell dysfunction, and insulin resistance. I am not going into detail. Family history of diabetes is very important because young onset diabetes have more significant history of one or biparental diabetes compared to the adult onset. So if you get a young onset type 2 diabetes, you will find a family history of diabetes in mother or father most likely compared to the adult onset. Similarly, ethnicity, certain medications, very importantly for all of us, antipsychotics and steroid can cause or increase the risk of young onset diabetes. We have to be very careful, and there are evidence-based data to show. I have already mentioned the intrauterine environment. There are many patients in young onset type 2 diabetes has some degree of lipid disabnormality like low HDL and high triglyceride. Hypertension is common comorbidities. Similarly, fatty liver, socioeconomic disadvantages, and last not the least, genetic factor are the most important risk factor, and there are comorbidities that can interplay in a very complex manner to develop young onset environment. In a short, genetic factors and various environmental factors interplay to produce this young onset type 2 diabetes, and the underlying mechanism we still do not know. Now if you look at the complications of type 2 diabetes in young, it is not that if you have developed diabetes in young and you will not get any complication related to diabetes. Is not true. There are plenty of data to show that it is as harmful, even if not greater harmful than adult onset type 2 diabetes. So if you look at the glycemic control of this from the two-day trial, there is after 3 years the HbA1c gone hayward. 2/3 of the patient having HbA1c more than 8%, only say 20-28% having HbA1c less than 6%. So most of them having uncontrolled diabetes. You can see the 19.2% is the baseline prevalence of hypertension in this group, quite high, and there are also 20% or so prevalence of dyslipidemia in this population. So they are having at least 2 important risk factor comorbidities in this group of patients, with majority having uncontrolled hypertension in today's cutoff. If we look at the individual complications, particularly microvascular complications like nephropathy, retinopathy, and neuropathy, the nephropathy is one of the important complications. elevated albumin excretion and hyperfiltration is quite common and increases by two times in 5 years duration. So it is not a benign condition. Be very careful. Young onset diabetes is not a benign condition. If it is uncontrolled, if the HbA1c on the higher side, if you have comorbidities, nephropathy is a very common complication in this group. So you can see the baseline prevalence and the increase after 5 years or so. Retinopathy, that today was, the trial was is a very particular about examining retina from the very beginning, fundal photography, and they use the protocol of ETDRS, that is the standard protocol in the examination of diabetic retinopathy. You can see the prevalence of today and such around 13.7 and 9.1% of any form of retinopathy, be it non-proliferative or proliferative retinopathy. So there is a significant amount of patient having retinopathy. Consider it as a youth type 2 diabetes, not adult one. And it is also associated with longer duration, later age of diagnosis, and poor glycemic control. So in this group, the glycemic control, particularly today, was not proper, so they have high degree of diabetic retinopathy. And it is very important to understand again that some specific ethnicity like Paimai Indians have shown even more higher prevalence of retinopathy in young onset type 2 diabetes. Regarding neuropathy, you can see the baseline prevalence was 1%, and after the study it was around 17.7% in such study populations. And all these three microvascular complications was found to be more common with youth type 2 diabetic compared to the type 2 diabetic in adult onset. So it is not like a myth that it does not have any impact on the youth, and very surprising but not uncommon that this youth onset type 2 diabetes has a more complication compared to the similar compared to the similar type of type 1 diabetic patient. So type 1 diabetic patient in youth has less chance of developing complications compared to the type 2 diabetes with having so many comorbid risk factors. It is not that type 1 diabetes is dangerous, it is a type 2 diabetes which has got more complications. The cardiovascular complications, again, there was a myth that in young age with diabetes you may not have cardiovascular complications. This is wrong. With the background of this baggage of comorbidities like hypertension and dyslipidemia, though we have not calculated the risk of using nicotine and other risk factor, it is very important to understand that from the today's trial, 25% of youth with type 2 diabetes of say 5 years duration have some degree of cardiovascular change, particularly with those with having hypertension. And there are risk factors like male and higher BMI, which actually complicate the matter worse. So blood pressure, male sex and high BMI is associated with more chances of developing cardiovascular disease. In echocardiogram study have shown high degree of left ventricular mass and adverse left ventricular geometry. This is found in echocardiography. It is relatively high as compared to our normal finding. So this is a finding from today. I have no way to explain it, but it is quite common to find out some degree of left ventricular abnormality in echocardiogram. With the longer duration, arterial stiffness, reduced heart rate variability, parasympathetic and sympathetic abnormality are quite common in this group of people, and it is found to be 8% in the today population after 7 years of randomization. In such study, they have also shown high degree of cardiovascular autonomous changes like 15.7% and arterial stiffness around 50%, which is quite high, unexpected in young type 2 diabetic patient with a mean duration of 7.9 years. So you have some early, some late complications of cardiovascular disease found in young type 2 diabetes. It's not that heart is spared or cardiovascular system is spared in young type 2 diabetes. So if you are diabetic for longer duration, you have got comorbidities, you are going to get cardiovascular disease very early. It is not that adult, it is youth, they are also affected. There are also a lot of psychological morbidities, comorbidities found in this today's study, like binge eating behavior, depressive symptoms, and exposure to stressful life events are also found to be quite high in this population. This has to be taken care of because this is closely related to management and follow-up. So anybody who is not psychologically fit is not going to get proper treatment, or you are not going to follow up them properly. Regarding the risk of mortality, it is very important. I have already explained that it is not a benign condition. It is associated with both macrovascular and microvascular complication. So the risk of mortality is definitely going to be high. And studies from Sweden, SARS data have clearly shown there is an increased mortality from all cause, not only cardiovascular or microvascular, all cause mortality is high in young type 2 diabetes compared to the control. Now, what are the future direction and clinical trial opportunities? I am not going into management. It is very important to identify young people at risk of developing diabetes. I have already shown you the risk, and there are a lot of risk categories. There are, recommendations from various bodies like ADA, EASD, and IDF. So name someone. There are a lot of strategies to identify the risk at population. Please identify those people who are risk, particularly obese, family history, having comorbidities. They are going to develop diabetes early, and this diabetes is dangerous. That will kill them. And as I mentioned, early diagnosis and management is very important. I am not going into the management part, but again, there are a lot of lacuna as far as the management of young type 2 diabetes is concerned, because below 18, you have no evidence of safety as far as the most of the anti-diabetic agents are concerned, except metformin and insulin. And we need evidence-based guidelines. There is a serious lack of evidence-based guidelines as far as diagnosis, management, and what I'm looking for in the future. Thank you very much.
Hello. Thank you, Dr. Purushottam Chatterjee, for very nicely explaining epidemiology, risk factors, all the micro and macrovascular complications of young onset of diabetes. And I think that there should be a national program like National Tuberculosis Control Program. There must be a national program to prevent diabetes and heart disease in India, because epidemic is going on, and lifestyle measures should be given importance, along with, as we are having more and more drugs which can prevent cardiovascular and renal complications. So young onset of diabetes, because they are developing diabetes at earlier age, they are having more complications, they are having long-standing diabetes. So all the diabetes-related complications, they will acquire at earlier age, and the manpower will be lost in productive age group. So it is a serious concern. Now this forum is open for questions.
Before that, may I have a comment to Dr. Chatterjee regarding screening. Actually, with intrauterine screening also, and with positive family history, obesity, NAFLD, PCOD, everything should be taken in account. All said and done. Actually, regarding treatment or screening after treatment, after screening the treatment procedure, there is no as such guidelines. Apart from metformin, do we consider GLP-1 RA with SGLT2 would be a good choice for this?
Thank you, sir. As far as management is concerned, definitely the first thing is the lifestyle management, and you have already mentioned, and I've also told in the identifying risk factor. Regarding management and your comment on GLP-1, yes, there are studies to show that GLP-1 is quite effective and safe. SGLT2, there are studies going on, but we don't have enough data to prescribe SGLT2, particularly below age 18 years. But you can use 18 years and above all the drugs available. But we are more concerned about people below 18 who cannot give consent and are included in the trials. So this is the biggest problem. So we do not include below 18 into any clinical trials.
I have one
So
question.
a more number of patients should be included in SARCH and Today trial.
I agree with that.
I have one question.
Yes, sir.
Actually, I want to know that we are very much concerned about the rising trend of type 2 diabetes in the young age group. Is there any rising trend in type 1 diabetes diagnosis in that group?
It's a very important and pertinent question. So we have now the highest number of type 1 diabetes in the world, India. So definitely there is an increase in type 1 diabetes. Considering the number of population in our country and the younger population, it is increasing. We have quite a high number of type 1 diabetes in India. So we are having the highest number of type 1 diabetes in the world as far as the population is concerned.
Yes, Dr. Bera.
So if you just compare in the management of diabetic patient, particularly young and the old, so the recent scenario is that is the 2 drug is better than the 1 drug, and if you have to target the diabetic patient very early with the combination therapy. Is it true for the young and is the old? Is there is any difference in, because nowadays there is also data there are showing better than go to the combination therapy from the very beginning. You can also go for the sequential therapy as well. So is there any difference between the young and the old in management of diabetes?
Difference is one that we know the management of adult type 2 diabetes above 18 because we have all, whatever discussion we are having is about 80 adult. Below 18 we have very few evidence, and I am again repeating, it is metformin and insulin, they have the age. So you have to start with metformin and insulin, and other you can use as a off level.
I have a very simple question. So how the Indian young onset type 2 diabetes, they differ from Caucasian young onset type 2 diabetes mellitus?
They are different in both phenotypically and genotypically, and they are different in various aspects. Whatever data we have with us, it shows that we have got excess visceral fat with similar BMI. Second is probably our population at young onset type 2 diabetes have severe insulin deficiency compared to the adult onset and the Western European one. And third, probably have different genes playing the underlying pathophysiology of generating type 2 diabetes in the young. So it is the genetics that is playing the important role, and also that leads to a very important gene and environment interaction, and we have got this difference. So we are phenotypically and genotypically different.
So I think if there is no more question, Dr.
I
Somani.
have 2 comments to make. Number 1, regarding diagnosis. By the time we diagnose a case as diabetes, we are already late. So in those patients who have risk factors, as you have mentioned, shouldn't we go for early screening, number 1? Because what we practice is when we go for diabetes management, when diagnosis, when he has already some symptoms. But we must remember that as a broad generalization, any organ dysfunction in the body can compensate to a large extent till 60 to 70% of the organ is destroyed. So early screening, though it remains a wishful thinking in our resource country, but early screening should be stressed upon.
Absolutely, and this is further strengthened by the fact that with availability of INDI-DAP study, there are a lot of patients suffering from pre-diabetes in young age also. So as per ADA and ESD, they have recommended using some tools to identify who are at risk and testing for diabetes and comorbidities. Even at the very early age, say around 10 years or so.
I think every good thing should come to an end. Thanks a lot to our speaker, Dr. Purushottam Chatterjee. Give him a big hand and applause. Good round of applause.
Thank you, sir. Thank you. I would like to request you to kindly stay on stage for the felicitation. I would like to request chairpersons to felicitate our speaker today. It's a small token of appreciation from social welfare organization Shongbedon. Sir, kindly. Sir, kindly stay on stage for the felicitation process. Sir, Dr. Ashok Mukherjee, kindly for the felicitation. Thank you, Speaker Sir, for the wonderful scientific session.